Now, if the patient is having recurrent issues and we are unable to get to a point where we cannot manage conservatively, then we need to plan for some form of an operative treatment as well. But as I told you, our main aim was actually of all the history examination imaging was to actually diagnose where exactly is the issue. Is it ligamentous? Is it muscular? Or is it osseous? Same is the case with the operative treatment, that we have certain specific goals which we need to achieve with, or we have certain principles of our operative treatment in the case of recurrent patellar dislocation. And main principles is depending upon if it's isolatedly medial patellofemoral ligament problem. For example, patient had an acute injury which happened quite a long time ago. Patient ruptured his or her medial patellofemoral ligament, but now is having a chronic instability due to insufficiency of medial patellofemoral ligament. We can go for either repair or strengthen the medial patellofemoral ligaments. Repair if it is possible, but if it's not possible and it's gone into a chronically insufficient medial patellofemoral ligament, then we can go for reconstruction of medial patellofemoral ligament as well. Now, reconstruction may involve it could be autologous reconstruction, the taking either the tendons or muscles from the body itself, or it could be allograft reconstruction as well. Autologous or autograft, which is usually taken, involves semitendinosus and gracilis muscle, which can be used in the place of medial patellofemoral ligament, so that its actually strength is strong enough that it can hold the patella in its place and acts as a static constraint as it was being done by the medial patellofemoral ligament. Or we can go for allograft reconstruction as well, but then that again had its own pros and cons, as we are using an allograft in a human body. Other includes there may be involvement of realign the extensor mechanism so as to produce a mechanically more favorable angle of pull. Why we need to do that? Because once we are sure that the problem is with the osseous anatomy or bony anatomy, then we probably need to realign the extensor mechanism to produce mechanically more favorable angle of pull. That is, we align by use of an osteotomy the patellar ligament in such a way that actually the patellar ligament pulls the patella more medially rather than pulling it more laterally. We will be defining different osteotomies. For example, there is Ulm-style trilat osteotomy, there is Fulkerson osteotomy. Different osteotomies are actually in place too, so that to recreate this mechanical pull, therefore tend to reduce the tendency of patella going more laterally. The other principles include is the treat trochlear dysplasia if present and predisposing to instability. Now the problem could be in the proximal portion as well. This could be the trochlear dysplasia or flattening of the trochlear groove. There could be increased patellar tilt, which may be able to find it on the Merchant views. When we need calculate the congruous angle and patellar tilt angle, we may know that probably the problem is with the increased patellar tilt, or there may be problems such as lateral condyle hypoplasia. Therefore, if the problem is over there, then you need to address it over there, leading so that to reduce basically the increased lateral subluxation or dislocation of the patella. The main theme of all these principles is that if it's ligamentous issue, we can treat it by repair or reconstruction. If it is bony issue or bony problem, then we have to go for some form of an osteotomy. Usually there is another way of saying it as well. Usually in case of children, we always say that protect the physis and don't go for any bony osteotomy or bony procedure straight away. And that is also some form of arbitrary sort of they have kept in this way that for the children you can only go for some form of a reconstruction, even if it is a problem. The reconstruction is always, a repair is always ligamentous. No bony procedure is actually done on the children, but when they become adult, we can go for ligamentous reconstruction and repair along with the bony procedures in form of osteotomies or even the tibal tubercle distalization procedures as well. Now coming to the direct medial patellofemoral ligament repair. As I told you, if the problem is that patient had acute injury a long time ago and resulted in acute dislocation which was reduced, when then we give brace for 4 to 6 weeks, and once the acute swelling settles down, pain settles down, hematoma settles down, then patient can go for direct medial patellofemoral ligament repair. And this can be, nowadays it can be done arthroscopically as well as the open procedure as well. But if this repair fails, then we may have to go for some form of a reconstruction, and reconstruction is usually done more with a use of an autograft such as semitendinosus and gracilis. And these are actually used to reconstruct the medial patellofemoral ligament and attach it towards the medial side of the patella, so that it actually pulls patella, keeps patella medially, and doesn't allow us to dislocate more towards laterally as well. After medial direct repair of the patellofemoral ligament, we can also go for suprapatellar realignment osteotomy or realignment procedure called an install procedure as well. In this, they can appreciate that actually as the patella is a sesamoid bone, on the all sides it's actually surrounded by quadriceps muscle. On the inferior side you have patellar tendon, and on the top of it you have a quadriceps tendon. This is actually plicated so that it actually results in more of sort of a strength to the patellar tendon. Therefore it does not actually allows the patella to dislocate further laterally. But this is again a realignment procedure if the problem is with the increased Q angle and the problem is with the malalignment of the patellar tendon. Other options, instead of going from some suprapatellar procedures, we can go for infrapatellar soft tissue realignment as well, called as Rock's Goldberg procedure as well. In this, if you can appreciate that instead of to reduce the pull of the patellar tendon laterally and tendency of the patella to subluxate more laterally, what has been done is that actually the patellar tendon is divided into half, and half of it is actually moved medially below the semitendinosus and the gracilis muscle is actually attached over here. This is called as Rock's Goldberg procedure. Therefore, initially this whole pull was pushing it more laterally. Now some part of the patellar tendon is actually pushing the patella more medially. Therefore, overall pull which pushes it laterally actually gets reduced, and therefore this reduces the tendency of patella to go more laterally. This is one option of soft tissue procedures. But if the soft tissue procedures fail or are unable to actually reduce the patellar tilt or patellar dislocation, then we may have to go for some form of bony procedures as well. And bony procedures include infrapatellar bony realignment osteotomy, such as Amsel Trilard procedure as well, which is now we can also go for either this procedure or for Fulkerson osteotomy as well. Now this Amsel Trilard is actually medialization of the tibial tubercle. Tibial tubercle, if you see it over here, tibial tubercle osteotomy is done. It is pushed more medially. Therefore, the force or vectors which are acting on the patellar ligament actually push patella medially rather than pushing it more laterally. This is one way of doing it, and this is a bony procedure which cannot be done in the children. We have these bony procedures only reserved for adult population. Other option is Fulkerson osteotomy as well, in which actually instead of pushing it more medially, because this procedure has its own pros and cons as well, because when you're pushing it too medially, this if you see it over here, the medial patellar facet touches the medial femoral condyle as well, and these usually patients then later on complain of having a medial joint pain as well as medial sided patellar pain, as they have increased tendency to develop medial femoral arthritis as well. Therefore, other option is to go for Fulkerson osteotomy. Fulkerson osteotomy is basically anterior medialization of the tibial tubercle. Medial tibial tubercle is not completely medialized, but rather anterior medialized. As a result, it actually produces the same effect of Amsel Trilard, that it reduces the pull which was initially lateral to the patella to make it medial to the patella, but with less strain on the medial condyle as well as the medial facet of the patella as well. And these are some of the procedures which can be done. Now the main theme or the principle is of the patellar procedure, the operative procedure is that if you can, the problem is with the ligaments, you can either go for the repair of the ligaments or reconstruction. If there are multiple problems, then we can combine the procedures along with the reconstruction as well as some bony procedures as well. But remember, the bony procedures usually are not done in the case of children, they are only reserved for adults. And when we are talking about bony procedures, we can go for realignment procedures as well as bony osteotomies as well. For example, like Elmsal trilard or Fulkerson osteotomy as well. All these procedures come under the heading the operative procedures for recurrent patellar dislocation.